Tonight we're going to talk about arthritis, and really what I wanted to do tonight was not necessarily to talk about what the latest and greatest surgical intervention is, although we can definitely get into that, and I encourage people to ask questions, but also to talk about, like, how do we treat arthritis as sort of a chronic degenerative process? How can we avoid surgery? What can you do to sort of not need a joint replacement? And so we'll just go through what I call the user's guide to self-management, because we're all going to get arthritis, let's face it. I mean, it's part of the sort of aging process that we're programmed to self-destruct. As we get older, our tissues just begin to break down, and it's kind of an inevitable thing that we're going to wind up getting some of these degenerative conditions. And so the goal of this talk is to sort of try to educate people on, what can you do to try to mitigate some of this aging process as it affects the musculoskeletal system. And along the way, if you guys have questions, feel free to interrupt. And at the end, if there's things that I didn't touch on that you guys want to talk about, I'm happy to answer any questions that come up. So that's kind of the background. I hear this about 15 times every day. So there's a lot of different kinds of arthritis. There's about 100 different kinds, but osteoarthritis is far and away the most common, and that's what we refer to as kind of wear and tear arthritis. That's the one of just, too much wear on the body, and things tend to degenerate with time. It's basically, the definition of arthritis, arthro is the Latin root for joint. Itis means inflammation, like tendinitis, all these things. Essentially what it boils down to is the cartilage, which is the smooth gliding surface of the joint, wears and breaks down. And once it wears away, you get exposed areas of bone and you get bone rubbing on bone. It typically is an age-related phenomenon, although there are some types that affect people earlier. We typically see people that are middle-aged and older. That's most common sort of in the 6th and 7th decades, but we do see people in their 30s and 40s who are beginning to get arthritis. And it can really affect any joint. But the weight-bearing joints are the ones that we commonly see it in. We also see it in, like, the thumbs. It's very common. Some of the finger joints. Hips and knees, it's very common. Elbows, not so much. Shoulders, fairly common. And it's a progressive condition, which means that once you get it, it doesn't go away. There's no cure for it. The whole goal is trying to sort of delay the progression. So this is the head of the femur bone. This is part of the hip joint here. This is what normal cartilage looks like. It's smooth, it's glistening, it's kind of wet and shiny. And it has a coefficient of friction that's like 2 ice cubes rubbing on each other. It's incredibly smooth. When it wears out and it breaks down, it becomes rough, it becomes pockmarked, you get exposed areas of bone, and it gets misshapen. It gets bone spurs around the edge, and this is part of what causes pain. It's not just the breakdown of the cartilage. There's associated changes that happen when joints get arthritis. The ligaments and the tendons that support the joints, they get contracted. The muscles may get weak. You get bone spurs that build up on the edges of the bone. And you get excess synovial fluid in the joint, which is trying to cushion the ragged bone ends by making more fluid. So the whole joint structure can get affected by this, and that's why it's not just as simple as sort of, can't you just put some new cartilage cells in there and fix things right up? This is becoming kind of a public health epidemic, and part of that is because, the population is aging. There's more people living longer and staying active longer. So there's about, 1 in 5 adults have doctor sort of diagnosed arthritis. And about 20 million of us have some limitation in our physical activity because of arthritis. 1 in 20 adults has work limitations, and so it's a huge annual cost to the healthcare system. And this is part of the reason that our healthcare system is going bankrupt, is because, it costs billions and billions of dollars to manage these things at a public health level. Common symptoms of arthritis, pain and inflammation is sort of the hallmark. Joints get swollen, they get stiff, you lose range of motion, you may have sticking, grating, clicking, crunching, giving away, fatigue, and weakness. These are all common things that we see. And there's no cure for this, unfortunately. We have no way right now of getting cartilage to heal itself. So cartilage is one of these tissues that doesn't have a lot of cells in it. It doesn't have a lot of blood vessels like skin. If you cut yourself shaving, it heals up quickly because there's bleeding and lots of healing. But cartilage is kind of like an inert tissue. There's not a lot of self-renewing capacity and regeneration. So when it wears away, that's it. It's gone. And people have attempted, and we'll get into this a little bit later, to sort of grow new cartilage and try to figure out ways to engineer new cartilage And as of yet, we just haven't figured out quite how to make the same stuff that exists in the joints from the beginning. It tends to worsen with time, so it's a progressive process. So once this process starts, it kind of snowballs over time. And the time course of it varies. So some people have rapidly progressive arthritis. You x-ray them, and everything looks, yeah, you got some early arthritis, it's okay, try to live with it. And 6 months later, you x-ray it again and the joint is completely destroyed. In other people, it's a very slow process, and the rate of progression is unpredictable. There's no way I can look at one person and say, you're gonna go fast or you're gonna go slow. You really don't know. There's a lot of vicious cycles with arthritis. People get pain, they avoid using the joint because it hurts to move it. They get tightness in the muscle, they lose range of motion, and then stiffness causes more pain. So it's sort of, it hurts, they don't use it, it gets stiff, that makes it hurt more, they don't use it, it gets stiffer, and so this is a common thing that we see. Also, muscular deconditioning. Pain, they avoid using it, muscles get weak, lose strength. The weakness puts more stress on the bone because the muscles can't do the work, hurts more. And so the more it hurts, the less you use it, and then it just becomes sort of a vicious cycle. There's also this sort of emotional coping mechanism. So chronic pain wears on people. People who are in chronic pain, it causes stress, they get depressed. When you get depressed, your coping mechanisms, your ability to sort of fight off the emotions of the pain gets worse, and then your pain threshold goes down because of the depression and things like that. And so these are all common, normal things that we see that go hand in hand with the problem of arthritis. So, there's risk factors for arthritis, and some of these are things that we just can't control, like aging. It's an age-related phenomenon. We can't control aging. We can't modify that. We can't turn back the clock. Gender, it's more common in women. We can't change that. And genetics, there's definitely, we don't know of one specific gene. There's not one gene that you can test for, but there's clearly families where everybody gets arthritis and everybody has a hip replacement by age 50. Things like rheumatoid arthritis can be genetic. So it's a combination of sort of the nature versus nurture. There's probably some genetic susceptibility, and then whatever people do during their lives kind of brings it to bear. And we see some patients that have it everywhere. I've got patients that have like 2 hips, 2 knees, 1 shoulder, 1 elbow replacement. And other people, it may just affect 1 joint, and that's it, and they only have 1 joint affected. Modifiable risk factors are things that we can change to try to prevent it from getting worse. Obesity is one of the big ones. As we know, this is a big problem in sort of Western society now. Injury to the joint, repetitive overuse, too much stress on the joint, or trauma. If people have had a bad fracture, that can cause arthritis. Activity level usually means too much or too little. So even sedentary people who don't have any activity at all can get arthritis. And by the same token, people who really abuse their bodies can get arthritis. And so there's probably, like everything in life, kind of a happy medium that you want to strike. And smoking is a risk factor as well. Smoking causes damage to multiple tissues in the body just from the toxicity of smoke, and it impairs healing processes, and it causes tissue breakdown, including cartilage. So as we said, it's an age-related phenomenon. As you can see, as people 65 or older, about close to 60% of the population, has some form of arthritis. As you get younger, but still, this is pretty impressive. 45 to 65 years old, close to 40% of people report some degree of arthritis. And this is important because, baby boomers have now hit 65. People are living longer. People are much more active in their older years. They're still very engaged and want to stay active. And the prediction is that by 2030, the number of living people with arthritis is going to double. So we got to find ways to deal with this because it's just going to become absolutely epidemic. So this is the proportion, and this is sort of a population projection map, and it's the proportion of the population 65 and older. And basically what you see is that as we go out to the year 2030, 20% of the population is going to be 65 or older, versus if you look around now, we're at about 13%. So that's a huge jump in the number of people that are going to be 65 and older. And if you look at the percentage of patients that are 85 and older, every age bracket goes up here. So we're seeing a lot more people that are living into their 90s and even around age 100. And you got to have solutions for people in every age category. So in response to this growing epidemic, the AAOS is the American Academy of Orthopedic Surgeons. That's kind of our ruling body. And they've come up with some summary recommendations trying to guide physicians, medical providers, and patients on, what does the evidence say about managing arthritis? In other words, if we look at the scientific data, what does the scientific data tell us about what works and what doesn't work and what we shouldn't waste any time on? And based on extensive review of the scientific data that we have available, there's good evidence to support self-management and education, which means patients sort of educating themselves, taking control of the disease, empowering themselves, and sort of managing the disease process. Weight loss, it's a no-brainer. Exercise, and basically symptom-reducing medications. There's good evidence that these things can help. There's limited evidence for things like supplements. We'll get into this a little bit. Glucosamine is sort of the most common one. Braces, there's no evidence that braces really make any difference for arthritis, although they do work for some people. Alternative treatments is things like acupuncture, things of that nature. Arthroscopic surgery or just, sort of a cleanup operation. And interpositional devices are basically, people ask me, like, can't you just slip a little pad in there? Like, do you have to replace the whole joint? Can't you just wedge a little something in there? And the bottom line is people have tried it. And this doesn't, being in this column here, it doesn't mean that it doesn't work. It just means that the scientific data doesn't prove that it works. And so typically stuff in this category, it works great for some people, but there's also a whole lot of people that it doesn't work for. So this is the type of stuff where you say, well, you can try it, and see, and maybe you're one of the lucky ones and it'll work for.
What does arthroscopic mean?
That's like the little keyhole surgery where you put the camera in and you just make 2 little incisions and you don't have to open the whole thing up. And arthroscopic surgery for arthritis usually means just cleaning up the worn cartilage and smoothing off the rough surfaces. Not replacing anything. And the reason it doesn't work is because the cartilage is already gone and you're not putting anything back, and so, This was an article that was in the Wall Street Journal, Patient Heal Thyself, and I think this gets into this whole sort of self-management, patient engagement. And basically what they found, people have studied this extensively, people who participate in their own care, people who get involved in learning about the disease process and what the options are and taking an active role in managing it, tend to do better. They tend to report less pain, better quality of life. And this is true not just for arthritis, but for lots of diseases: asthma, congestive heart failure, diabetes, other heart diseases. This is proven that people that take an active role, they do better. And so it gives you some form of control, and I think that's important. And it yields psychological benefits, and those psychological benefits, like sort of mastering the depression, it does help with coping mechanisms and self-reported pain. So essentially, the whole goal of self-management is sort of not be the victim, but to move into this category here where you're like the master and commander of your own problem. You can manage it. Self-management, the cornerstones are keeping fit and healthy, good nutrition, having a good attitude about things, and sort of, being educated by a healthcare professional about what you can do. And this is this whole concept of wellness. And where this applies to arthritis is, arthritis doesn't really kill people. Like congestive heart failure can kill you, coronary artery disease can kill you, cancer can kill you. But arthritis doesn't really kill people, you know what I mean? It's not a deadly disease. It's a disease that sort of affects people's quality of life, but it doesn't really affect their life, so to speak. So we like to think of patients with arthritis not as sick patients, but as you're well, you're not sick, like dying sick, you have like a joint problem, but we want to think of this not as sort of treating a disease, but like a wellness thing. Taking somebody who's well and making them more well. So, I like to think of arthritis, again, not as a disease, but as a process. It's a progressive degenerative process. It's not a destination. It's sort of like the concept of the journey, it's like life. Like if you're looking for the destination, you're never going to be happy because you're never going to get there, It's sort of the journey of going through the process and managing it. So I think if you look at it like a journey, you won't get so depressed by it. So the one thing that wasn't on that wellness slide is patient education and engagement. And we've talked about this. You want to take an active role, not be sort of the victim, the passive bystander. And by the same token, there's a lot of information out there, right? So, this is the type of stuff that most of us access now if we're looking for information about something. You go on the computer or you go to the library and you're sort of confronted with, and you got friends that you talk to and your friends say, you got to do this or don't do that. And so there's all kinds of information resources that we have access to now that can kind of flood us with almost too much information. And so you got to be skeptical, number one. You can't believe everything you hear and everything you read. You got to do your own education and research, and you got to be savvy about it. You got to sort of like get involved in the education process and again, sort of be a skeptical consumer. I mean, if you're going to go buy a new car, right? You do some research beforehand. You think about what you want to get. You think about the features. You think about what the cost of the dealership is. You don't just walk in there and have some shyster like sell you a car. So, and it's because we have access to a lot of information, but there's good information and there's bad information. And so you do have to sort of be a little bit of a savvy consumer. Nutrition, there's no really compelling evidence about nutrition and arthritis, but I think it's fair to say that because over the course of our lives we put a lot of food in our body, that there probably is some impact of food, just as we know that too much fat and cholesterol can cause heart disease. A lot of these chronic degenerative conditions, they probably have, nutrition probably plays some role in it. And what people have found, and again, this is not level one sort of compelling scientific evidence, but this is sort of, there's an association between X and Y. Stuff that's probably not great for arthritic joints is stuff that promotes inflammation in the body. So, with these antioxidants now, like blueberries are full of antioxidants and tomatoes are full of antioxidants. There's been a lot of sort of interest in things with antioxidants playing a role in reducing inflammation. And the reason it's important is inflammation can cause not only tissue damage, but genetic damage as well. And some people think that the destruction to the genes can lead to things like cancer, higher risk for colon cancer. And so there's some thought that inflammation-producing foods can potentially cause inflammation of the joints. And typically it's saturated fats, trans fats, sugar, fried foods, and processed carbohydrates. The good stuff is stuff that can potentially either support bones and joints like vitamin D and C, or stuff that's inflammation reducing. Hang on. Okay. Omega-3, this is found in fish. Fish is a really good source of this. It's considered to be sort of a good anti-inflammatory. Broccoli, ginger, very popular. Berries, blueberries, raspberries, blackberries as well. Olive oil. People talk about the Mediterranean diet, and I see people that are from like, because Dover has a pretty big Greek community, so you see people like that grew up in Greece, that are like in their late 80s and 90s, and they look really, really good. When you say like, what's your secret? They say, oh, Mediterranean diet, I eat a lot of olive oil. So I do think maybe there's something to it. This was something that actually came out of Brigham and Women's Hospital, some research that they did. This was published actually this past year. The cure for arthritis. I mean, that's a bit of an overstatement, the cure for arthritis. But what they found is that fish oil, which is probably, omega-3, and aspirin can kind of work together. They can kind of have a synergistic effect to reduce inflammation that causes pain. So, these are like simple things like eat less red meat, eat more like, sea trout and salmon, and you might feel better. Weight's a big problem. And we know this, like this has been talked about. Childhood obesity is a big public health campaign now. And it's not just in America. This is like, a lot of the first world countries are struggling with this now. But America certainly, has problems with obesity. And the rate sort of keeps going up and up. And they follow, the CDC follows these statistics. But basically, this is followed by the body mass index. That's sort of like, there's a formula for it. It's like height in centimeters squared divided by weight in kilograms. And the bottom line is that, healthy normal is sort of 18 to 25. That's considered to be a normal body mass index. over 25 and between 30, this is considered to be overweight, and up to 29% of people are in this category. Up to 34% of people are in what they consider obese, which means a body mass index of greater than 30. And then morbidly obese is when your body mass index greater than 40. And so it's pretty alarming to think that only about 30% of adults in this day and age fit into what's considered to be the healthy category. And essentially what's happening is if you got more weight here, it's more pressure down there. It's just a pressure phenomenon on the joints. They're just taking more abuse over time. And there is a one-to-one correlation between weight and arthritis, 1-to-1. There's no question, and if you just look at the statistics here, the percentage of people, adults with arthritis by body mass index, the more your body mass index, the higher your chances of arthritis. And if you do the math here, basically one of these like Newtonian law of physics, every action has an equal and opposite reaction. You guys remember this from like high school. What that means is when there's a force pushing down, there's an equal and opposite force pushing up. So every pound here is 1, 2, and then it's the stress of the muscles trying to counterbalance it. So every pound here is 3 to 4 pounds here. If you're going up the stairs, it's 6 pounds. If you're running, it's 8 pounds. So it can really add up quickly. Again, it's a vicious cycle. We see this all the time. People say, well, like I try to lose weight, but I have pain, and so I can't exercise. And so, because I can't exercise, I can't lose weight. In fact, I'm gaining weight because I can't do anything to burn off the calories. And so again, this can become sort of a vicious cycle here. And it's hard, and there's really no, weight control is something that just about everybody struggles with because it's just hard to lose weight. Weight control, however, is really known to improve the pain from arthritic joints. It's one of these things that's kind of a no-brainer. If you have arthritis and you are not at your ideal body weight, it has to be part of the treatment plan to address the weight issue, because otherwise you're going to continue to put wear and pressure on your joints. It's also just good for your overall health. We know that things like diabetes and heart disease are correlated with being heavier. It's so it's maintaining ideal body weight. It also produces a positive feeling for people. Portion control, this is kind of a buzzword, like the super size, when you go to Europe, like they don't eat much. We eat a lot here. We consume large quantities of food, and if you go to Europe and you order a cup of coffee, it's like a Dixie cup, They bring you like this little tiny thing, and you're used to like the 40 ounce from Starbucks. And so I think that's part of the American culture, is that we consume. We are consumers. We have big cars and big TVs, big houses, and we just go big on things. And we're a little bit unique in that way. And so, restaurants are serving larger portions, and people are getting used to eating larger portions, and that's just kind of a cultural thing that we've all gotten used to. Surgical weight loss is an option for people. In some people, it may be the only way. Some people get to be so heavy that there's just no way they're going to lose it, short of having some kind of anatomy-altering procedure done. And it can be very successful, but you do have to be motivated, and you have to go through a screening process, and there can be some risks associated with this. So there's many people who say, I just don't want to I don't want to go there because I don't want to take the chance. But the bottom line is it's an important part in the management of the process is weight control. Nutraceuticals, this refers to various different joint supplements. You hear these things advertised on TV and on the radio on Sunday morning, infomercials, and there's a lot of stuff out there. The bottom line is none of them are regulated by the FDA. So you don't really know what's in them. They don't, nobody's sort of studying. Occasionally Consumer Reports will do an article and they'll kind of look and say, is the stuff that's like in the ingredient list really in the powder? So it's, I think the feeling is that a lot of the benefit may be from the placebo effect. A lot of these things have sort of these assertions that are like not really true, like shark cartilage will like rebuild your joints, and it just simply isn't true. There's just nothing that rebuilds joints. Glucosamine is one that has probably received the most attention, and like we saw on that guidelines list, it sort of fits into the limited evidence to support category. But the bottom line is we do have patients that get symptom relief from this. Some people get better when they take it. Whether it's placebo effect or whether it works, it doesn't really matter, because if you take it and you feel better, that's all that matters. And a lot of times there's insufficient data to recommend the routine use for this. This means that doctors shouldn't really tell patients to take it. I mean, the way I look at this is insufficient data sometimes just means we don't know. We don't have good data. It's hard to do human studies. It's hard to make humans the subject of studies about treatment, because if you do that, you're automatically if you want to do a randomized, placebo-controlled, double-blind study, that's kind of the gold standard for figuring out if something works. You have to randomize somebody to the group that's not going to get something that could potentially be beneficial. And so ethically, that raises an ethical dilemma for the scientific field, particularly for things like chemotherapy. If you're going to randomize somebody to the group that isn't going to get it, they could die, if the group that's going to get it could live. So these are big ethical problems, and sometimes insufficient data just means we can't do the study, Veterinarians swear by this stuff. It's in like every dog food, and they give it to horses because horses get sore joints. And so in the vet world, they're big believers in glucosamine. And the bottom line is it's not cheap, it's safe, it doesn't have many side effects, it's not bad for you, because it's kind of all naturally occurring stuff. And whether it works is a matter of sort of, try it and see. The contention is you got to be on it for a couple of weeks, and you got to take it 3 times a day, and you have to be fairly rigorous about taking it if you want to see the benefits. I actually take it, believe it or not. And for years I told people, this stuff doesn't work. Don't waste your money on this stuff. And then I got a frozen shoulder. I got this like sore shoulder last February, and I was desperate because I was in I couldn't sleep at night. It was killing me. And I was, and I'm like one of these people, I'm not going to do anything about it. I'm not going to get an MRI. I'm not going to see anybody. It'll work itself out, I'm like the classic bad patient. And so anyway, in February, it was killing me so badly. I was like, I'll do anything to get rid of this pain, and I don't want like anything heavy. So I started taking it because I'm like, what have I got to lose? And sure enough, I swear, it feels better. And if I don't take it, like if I go away for the weekend and I forget to bring it with me, by Sunday night, I'm like, God, it's killing me again. And then I used to totally not believe in this stuff, and now I'm like, I don't know, maybe there's something to it.
Arthritis in your shoulder?
I don't know, because I've never gotten it. I refuse to get it x-rayed, because if I do, I don't want to know. But I can still do stuff, and as long as I'm here, I'm okay. It's when I get out there that it hurts. So it, I'm not going to do anything about it.
Do you take glucosamine when you're taking NSAIDs?
Yeah. Yeah, it's totally safe. Yeah.
When you say that's not cheap, I mean, a ballpark figure, what does it cost? What does it come in pill form?
Pills.
It comes in pills, and I think you can get it in powder form too.
So it's...
Yeah, and I get the generic Rite Aid brand pills, and it comes in a bottle of 250, and each pill is that big.
What is a generic for that?
Yeah, there is.
For something like that.
I can't remember. I mean, maybe like $20 for a bottle of 250, and I take 6 pills a day. I take 3 in the morning and 3 at night, and so a bottle lasts a pretty long time. Lasts me a month or so.
So with Tramadol and Celebrex that she's taking...
Yeah, you can take it. Yeah, it's told. Yeah, absolutely. Exercise. Exercise is on that list of this is what you should do for arthritis. And people kind of say, well, that doesn't make any sense, because if your joint's worn out, why do you want to put more wear and tear on it? But there's no evidence that exercise wears out a joint faster. So to the extent that it keeps joints moving, it supports the muscles, it keeps the muscles stronger, and it sort of supports cardiovascular health, and there's evidence that it sort of helps people feel better about themselves. It's beneficial to people with arthritis to try to exercise. It has to be done in safe ways that don't inflame joints. It's proven with other chronic diseases, like self-management. And there is scientific evidence that justifies the benefits of arthritis, and if you stick with it, these benefits can be sustained. So the problem with our society is that with all this technology around us, we're no longer hunter-gatherers. I mean, 500 years ago, people went out and shot a boar and picked berries and chopped wood. you know, and that's what we did. But now we sit around and work in cubicles on the computer all day. So, you know, most adults are sort of sedentary. I mean, as a rule, I mean, talking about generalizations in the population at large, 1 in 4 adults never exercises. Only 1 in 5 exercises regularly, you know. So we probably don't exercise enough as a society, you know, which has implications for weight control and you know, all these other chronic health conditions that can sort of gang up together. So, you know, it improves flexibility. There's the weight loss benefit. It improves muscle strength. It decreases fatigue and improves energy, cardiac fitness. People sleep better when they exercise, and you have an improved sense of well-being. The key points, and this is directly from the Arthritis Foundation, is that any physical activity is better than none, you know. Moderate, low impact is safe. In other words, if you got an arthritic knee, you don't want to be doing like Stairmaster, you know what I mean? Because that's just going to aggravate it. But you want to be riding a bike or something that's low impact and it's kind of, you know, low level, keeping things moving. You know, it's got to be a priority. So people always say, well, I don't really have time to exercise, you know, I'm busy, I got a lot going on. But you got to make it a priority.
What's your opinion about treadmill? I had some knee problems. I have a slightly torn meniscus. It's not serious enough to, you know, operate. I have arthritis there settling in. And they said for me not to use a treadmill.
Treadmill is a little bit of a hard surface. Some of them are more cushioned than others. I certainly wouldn't run on a treadmill, you know, but you know how you can get a fantastic workout on a treadmill? Jack up the incline, you know, and it's like hill walking. So if you raise the incline, 0 is sort of flat like this, and if you raise the incline to like 6 and just put it on a fast walk, like speed of 3.5, it's killer. You know, it's a great workout, but you're not pounding, you're not landing on it. It's sort of, you know, and you want to wear cushion shoes with like a really good spongy cushion. So, you know, I think that like the bike is the least impact, right? Because your foot's always connected. So there's 2 kinds of exercise. One's called closed chain and one's called open chain. Closed chain means your foot never leaves the device. So an example would be a bike where your foot's always on the pedal, or like an elliptical machine where your foot is always connected to the thing. An open chain would be your foot leaves the device and makes contact with the device like running. So in general, I think open chain is going to lead to more impact, and closed chain, and walking to some degree is open chain, but the impact is not quite as bad because you're not crashing down on it. And you can break it up into small amounts during the day. You know, so you don't have to sort of go crazy. I think some people say, oh my God, like it's going to drive me crazy. I got this huge list of stuff I got to get through. You know when I do this? Like my house at the end of the day, totally unpredictable. You know, kid's going to have to get dropped off at gymnastics and then picked up, or they got swimming practice, you know. And so like if I come home from work and think I'm going to get exercise, it will never ever happen. So I do it when I first get out of bed. I roll out of bed and I exercise and I'm done, and I take a shower and I'm out the door and I'm gone. And I've been doing it for 10 years. And like for me now, it's just like it's a habit. And that way I can get it done. Everybody else is asleep. I'm not bothering anybody else. I'm not interfering with anybody else's time. I'm not taking time away from my family or my kids. And it's done. And then I feel good for the day, you know, and I've kind of like justified a little handful of peanut M&Ms because I exercise, so it's all good.
What's your opinion about non-weight bearing? Like, there are some exercises you can do that actually takes the total weight off of your spine. One thing that had worked for me is during the summer, I would suspend myself in the pool, and kind of when you do that, it kind of stretches your spine. But I know that there's an athletic center in Portsmouth that has a saltwater pool.
Yeah.
And they're saying that really does help with arthritis. You know anything about it? I'm
Yeah.
asking specifically about the salt water. Does that make a difference?
I mean, I don't know a lot about salt water other than, you know, salt increases the buoyancy because the water's a little bit denser. So the buoyancy is different between like fresh and salt water. And there may be something about what the salt does to the buoyancy and whether or not it has some kind of therapeutic effect like Epsom salts, you know, like it might. But the bottom line is that pool exercise is great, particularly when people have a lot of pain and weight bearing causes pain. The buoyancy of the water basically helps relieve it because you can still do resistance work without the weight pressure on the joints. And so I think water exercise is a great way to do it. And also a lot of these pools are warmer, and the heat raises the body temperature, which increases blood flow, and blood flow tends to loosen things up, like warming up a joint. And by getting rid of some of that stiffness, I think joints feel better. So I think water exercise is a very good way to go. Walking is certainly good. You want to do a combination. You want to do some strengthening because you want to support the muscles that are going to take the stress off the joints. So muscles basically unload the joints. So you want to do a combination of some stretching, flexibility, strengthening, and you want to burn some calories and sort of get your heart rate up. So that's this is sort of like the Arthritis Foundation's like little exercise pyramid here. Formal physical therapy. I think it's good for some things. You don't want somebody cranking on an arthritic joint. You don't want a therapist like hungry to have a heyday with your joint, But on the other hand, therapists are very good at sort of assessing deficiencies, weakness deficiencies, where something needs to be kind of tuned up a little bit. They're very good at assessing things that are stiff, selective stretching exercises that may benefit people. They can be very good at sort of designing an exercise regime. So if you say, look, I got a Planet Fitness membership and I don't really want to pay the $25 copay that it costs me every time I walk in the door, but can I see you once and you kind of show me what to do, and then I'll go take it to Planet Fitness and I'll do it on my own. I think that's a very good option. They also have some what we call modalities: ultrasound, iontophoresis, electrical stimulation, which are some techniques that they can use to really reduce inflammation in people if it's acute, and so they've got some sort of therapeutic things that they can do. And they can assist people in finding ways to do stuff that they need to do on a day-to-day basis and sort of modify activities to make them manageable. A lot of people with hip arthritis, they can't put their socks on. They can't bend their hip to get their socks on. So sometimes therapists are good because they can teach you ways to do things, how to get your socks on in the morning. And also, assistive devices. People don't like to use a cane or a walker, but the fact of the matter is they take stress off joints, and so it's, and they can help with fitting these and training people. How do you use a cane? Most people, a lot of people don't know. You put it in the opposite hand. Most people conceptually think if you got a bad right hip, you put the cane over here, but you actually put it over there. And so they can assist people in sort of incorporating those things. Medications, the NSAIDs, the non-steroidal anti-inflammatory drugs, are sort of the classic ones. There's a whole lot of them on the market, including ones that are prescriptions and ones you can buy over the counter. Theoretically, they all really work the same, so buying generic ibuprofen is not a lot different than having some fancy prescription one.
Do you have any substitutes for people that can't use that?
Yeah, well, that's the problem, because there are some people with kidney disease or blood pressure problems or GI problems, stomach ulcers, that can't take these medications. And so the main substitute would be Tylenol. If you're talking over-the-counter medications, Tylenol. Prescription medications, Tramadol, I think what you mentioned, is another one that's a non-narcotic pain reliever. And then there's sort of like the narcotic pain relievers, and in general we try to discourage people from getting into those because they're addictive and because you develop a tolerance to them, and so the more you take those, then all of a sudden you need a higher dose and a higher dose, and pretty soon you're hooked on it and it doesn't work anymore. So medication is one of these things. I kind of think of medication as like you got like a broken part and you're trying to take a pill to fix it. And it's only so successful. And that's why it's part of sort of a global management algorithm, the exercise, the Motrin, all the things sort of feed in together, because just taking a pill for something that's worn out, it's like trying to put a Band-Aid on a broken axle. Topical remedies, there's various creams. Capsaicin is like based on Mexican hot peppers. They take like the essence of jalapeno and they put it in a gel. And basically, it's got some anti-inflammatory properties, but also what it does, I got a little typo there, it exchanges pain for heat. It's called the gate theory of pain, There's only so much that, think of a gate and like Larry, Moe, and Curly are all trying to get through at the same time, and they all kind of run into each other, and then one of them finally squeezes through. Some people think that pain signals going back to the brain is similar to that. There's a gate, and only so much stimulus can get through the gate. So if you have pain stimulus that's flooding the gate, if you flood it with something else like heat or warmth or vibration or something, which is like sort of the theory behind ultrasound, the pain signal can't get through as much, and so it doesn't seem to hurt. And that's part of what capsaicin does. There's also Voltaren gel. People use BioFreeze, which you can get over the counter, I think. And these have some local anti-inflammatory effect, but also work on the gate theory. Cortisone injections, these have been around forever, and they work. I mean, people can get fantastic pain. I've had 2 in my shoulder. I got 6 months of great relief. And so, cortisone is a great way of getting rid of pain. And people always ask, well, does it do anything? Are you building the joint back up? And the bottom line is the main benefit of cortisone is pain relief. It is an anti-inflammatory, and that may be part of the way that the pain relief works. And they can last for months, and some people don't get any relief from them at all. Some people get 2 to 5 years of relief. Other people get 3 weeks. Some people get 6 months, and it's variable by the person and by the severity of the disease. It's not a cure. We know that when we give people cortisone shots for arthritis, it's going to come back. There's some, people always say, well, how many can you have? I've heard you can only have 3, The science behind the number of injections and the frequency, there's not a lot of good science behind it. It's a lot of old wives' tales. You can only have 3 to 4 in a joint. The concern is that cortisone inhibits collagen production, and collagen is what we're made of, right? All of our connective tissues have collagen in them. So there's some concern that if you put too much cortisone in a joint, it'll weaken the bone and weaken the cartilage, and eventually it's making the arthritis worse. So it's making it feel better today, but it's going to make it feel worse tomorrow. And that's the concern. But we do have some patients that absolutely can't have surgery. They have a heart that they will die on the table if you operate on them, and their doctor has said, you may never have surgery on that knee. And we just they come in every 3 months and we give them a cortisone injection indefinitely, and as long as they're getting some benefit and pain relief from it, they seem to do okay. So the whole contention of like 3 to 4 injections and that's it, it's not really a hard and fast rule. You got to look at every situation and every scenario differently.
Is Kenalog a form of cortisone?
Yes,
And
yeah.
what about lidocaine?
Lidocaine is a numbing medicine like Novocaine,
Oh,
but we mix them together. So it's like a
Kenalog
Kenalog and lidocaine together.
Is there another one called something like, I can't remember.
Marcaine.
Who?
Marcaine.
Marcaine,
Yeah, it's another Novocaine. It's a longer acting Novocaine.
a number.
Yeah, so what you do is you combine them. You do like 4 cc's of lidocaine, 4 cc's of Marcaine, and 2 cc's of Kenalog. And then the lidocaine numbs it up right away. It works fast. So people get up off the table and go, oh, geez, it feels better already. That's the lidocaine. The lidocaine wears off in 2 hours. The Marcaine wears off in about 6 hours. So the Marcaine sort of extends the effect of the numbing, but the Marcaine doesn't work as fast. So if you just put the Marcaine in, then for 20 minutes, people, And so the lidocaine gives them the fast acting, and then the Kenalog kicks in over time. Because all the numbing medicine is worn off. But the other reason to mix them is because if you dissolve the Kenalog in the numbing medicines, it increases the volume so that when you inject it into the joint, it sort of spreads it around more. If you were to just put 1 cc of Kenalog in there, it would sort of get stuck like where you put it. You want it to sort of bathe the joint, and so we mix it in a larger volume so it sort of spreads around.
And that lasts longer. The
Yeah.
Kenalog is the one that.
The Kenalog is what lasts for a long time because the Novocaines are worn off like in less than a day. Joint fluid therapy, these are gels that we inject. Synvisc and Euflexa are the common ones. There's several on the market. They're basically analogs of hyaluronic acid. This is found in normal joint fluid. It's like this lubrication stuff that makes normal joints have fluid in them that keeps them lubricated. If you feel the fluid, it's viscous, it's slippery. It's like oil for an engine. And what makes it slippery is the hyaluronic acid. So some smart person said, geez, if you concentrated that stuff up into a gel and put it in arthritic joints, maybe people would get pain relief from it. And right now, it's only FDA approved for use in the knee. There's no really good reason for that. We use it in other joints. They don't pay for it in other joints, but we get free samples, and we put free samples in shoulders and hips. Results are variable. Some people get no relief. Other people get relief for months and months. So it falls again on that side of the guidelines where it's insufficient evidence to recommend for or against, which means it works great for some people and it doesn't work great for other people.
Is Synvisc one of these? Is this the same as Synvisc?
Synvisc, yeah.
Oh, okay.
Yeah. And then arthroscopic surgery, that's the sort of keyhole surgery that we were talking about. Can you go in and just kind of scrape the arthritis and clean it up and smooth it out? And does that work? And actually, there was this famous study that was done where they did a randomized trial, arthroscopic surgery for the knee. And what they did, believe it or not, they did this in a VA hospital, and they got consent for people. They told patients, we're going to do a randomized trial. You're going to agree to be in it. So it wasn't like human they weren't just experimenting on people. They got written consent from these people to say, in a group of you, we're going to do this in people with arthritic knees. A group of you, we're going to put the scope in there. We're going to clean it up. We're going to smooth it out. We're going to sort of debride stuff, make it look pretty. And in a group of you, we're going to put 2 incisions on the front of your knee and close them up and wake you up. And you're not going to know if you had one or the other. You won't really know. And then we're going to, follow you along for 3 months. And what they found is that there was no difference in outcomes between the groups. So that's a pretty good study to say that, like, the lasting benefits of doing an arthroscopic surgery for an arthritic knee, there's no evidence. It's no additional benefit over just physical therapy and medical therapy alone. So that's not a very good cure. What about cartilage regeneration? There's a lot of interest in this, like, can't you just get the joint to grow new cartilage? I mean, that would be like the holy grail of orthopedics, if you could get joints to build new cartilage. And people are working on this. Right now, they've had some success when you have a really small focal cartilage defect like this and it's surrounded by normal cartilage. And you can take some cells out, grow them up in the lab, put them back in there, sew a little patch over them, and they may grow some new cartilage. When you look at that new cartilage under the microscope, it's not really as good as the stuff that was there before. It's like scar cartilage. And they just haven't had success, when there's a larger degree of joint wear. So one of the problems is that when people get bad arthritis, it's not just that, like, the cartilage surface is worn away, they get erosion of the bone, The bone gets scalloped away here. You get bone spurs, you get malalignment. You can see this is a big knock knee. And the problem is if you just put new cartilage in there, you still have a big hole in the bone here. You still have the malalignment, and those problems are just going to wear that cartilage right away again. So there's a mechanical environment that you're putting this biological therapy into. And if that mechanical environment is deranged, like this joint, the biological treatment's not going to work. And that's one of the difficulties of it. It's not all a biological disease, it's a mechanical disease as well. So, but I think, nevertheless, tissue engineering, which is this whole concept of growing new tissue, making the body want to renew itself and heal, there's a big future in this stuff. There's a lot that we don't know. There's a lot that we're learning about how genetics works and how this can be leveraged to try to get the body to do things that it's normally not used to doing. And there's various different arms. There's, trying to get cells to make new cartilage, making scaffolds, that look like regular cartilage. So if we can engineer a scaffold that looks like the building blocks of cartilage and then put some cells in there, will it grow cartilage? And so this is an area of active research, but as of yet, we don't have, sort of the magic bullet. This slide should have been earlier with the other one on arthroscopy. But this is kind of an arthroscopic view of what arthritis looks like, where this is cartilage here, and this is bone here. And this is when, the cartilage is completely worn away there. And like I said, because the problem is the cartilage is missing, and you can't put it back, like, how's that really going to help? If you go in there and you sort of, clean that stuff up there, and maybe if you got a loose flap there, you sort of trim it up. It just doesn't solve the fact that you still got a big bald spot right there. Unispacer. So this is the concept of, can't you just, like, put something in there? And the unispacer was tried. The concept was, if you've got sort of a collapsed joint space here, rather than replace the knee, can't you just, like, put a little shim in there? and open it back up. And the bottom line is it's sort of like a good idea. Like a lot of things, it's sort of in concept. The concept is pretty good, but the practical application is just not reliable. The thing dislocates, the thing spins, there's nothing to hold it in place. And the long-term outcomes are really not known and have never stood up to the outcomes that you can get from joint replacement. So joint replacement is sort of like when all else fails and you've tried all the conservative treatment, joint replacement it's not really a cure for arthritis, but in a way it is, because arthritis being wear of the joint surface, if you put a new joint surface in there, you can't get arthritis again because there's no old joint, there's no cartilage left to wear out. So in a way it's a solution, and although we're not curing the disease, we are sort of curing you're not going to get arthritis again. It's been around for about 5 decades now, so during that period of time we've learned a lot about why these implants fail. And based on experience and failure, you can sort of engineer better ways to do things, better materials, better ways to put them in so they're not malaligned, better ways to fix them to the bones. And so I think that the success of these operations and their durability has gotten better over time. The other thing is patients' demands have changed over time. So, 20 or 30 years ago, you didn't see 80-year-old people wanting to ski, but I did a knee replacement on a guy on Monday, and he wants to be on the slopes in February. He's 80. And he got arthritis because when he was 68, he wiped out and he smashed his tibia and he broke the knee severely, and then he wound up with post-traumatic arthritis. And he still skied on that knee for 12 years until finally he said, it's done, but I want to be back out on the slopes. I can't wait for the snow to fly. So, that's what we're seeing, is we're seeing people who are older who still want to be very active. And so, this is what the industry is contending with to try to really give people better function and more durability. So if we think about what are the major advancements in joint replacement that have occurred, say over the last decade, some of it is the way that we put these things in. So the surgical approaches, we've learned ways to reduce the tissue trauma, to try to cut fewer muscles to get these things in so that the recovery can be faster and the overall damage to the body less. Better materials that last longer, that wear less. Pain management has been a big element of the recovery, so improved pain management, like immediately following surgery. Like knee replacements hurt, when you do a knee replacement surgery, it's painful. And so any degree to which you can minimize the pain or reduce it is going to get that patient out of bed faster. It's going to promote a faster recovery and better rehabilitation. Optimizing people. So when you go in for a surgery like this, you want to be in the best shape that you can be in. You want to try to exercise your muscles a little bit. You want to make sure your health is as good as it can be. If you smoke, you want to try to quit smoking. You want to make sure if you have diabetes that your blood sugars are in good control. And we've learned the hard way that it's important to manage all these other elements of people's general health so that they can have the best outcome. Blood management, we've gotten better at sort of less blood loss. Some of this relates back to tissue-sparing techniques. And so the risk of needing a blood transfusion has gone from 40% to about 5% within the last decade. Infection prevention, this is a big complication with joints, so screening people better ways to sort of prepare the skin before surgery so infection risk is lower. Rapid recovery programs, getting people out of bed. People used to be in the hospital for 2 weeks after a joint replacement, and it was like, lie around for a couple of days, and now you're out of bed. We do a hip or a knee replacement, and somebody, if our first case is done by 9:30 in the morning, they're walking down the hall that afternoon. We get them out of bed on the day of surgery, we get them up and going. And then care redesign. So there's a lot that goes into the process of getting a joint replacement. You don't just show up at the hospital and get it. You got to get labs. You got to see your medical doctor. You got to think about, am I going home? And if I'm going home, is my house ready? Do I have help at home? Do I need to go to a rehab facility? Where am I going to go to physical therapy afterwards? These are all parts of the whole sort of spectrum of, going from an arthritic knee to a recovered joint replacement. And so, part of getting through that successfully is designing the whole process of care and also trying to standardize it, because we know from things like the car industry that the more you do things the same way, the better you tend to do them. So if you can standardize these processes, then the outcomes tend to be better. We're up to about 800,000 yearly hip and knee in the United States. The number goes up every year. The projections are that by like 2025, this is going to double. So And it's because people are living longer, younger people are getting arthritis, and people that are older, are no longer willing. If you're 75, it used to be like 20 years ago, if you were 75, your average life expectancy was 2 more years. And if you knew you were going to live 2 more years, you'd probably say, I'm not going to bother with that. But if nowadays, if you're going to live to be 97, you're not going to live for 20 years in pain. People just won't do it. What patients want, they want to get range of motion, stability. They want these things to fit right. They want function. They want them to last for a long time. They want basically performance out of these things. What we want is really simple. We want our patients to do well. And we want to be able to do these reproducibly so that, the vast majority of our patients do well. Not just some of them. We want everybody to do well.
Is that a self-portrait?
And so again, there's a lot. This is a team approach, and the patient is part of the team. The patient has to be motivated. The patient has to know what they're getting into. They have to be willing to go through what it takes to get one of these done. And, we have anesthesiologists, physical therapists, medical doctors, social work, discharge planning, nutritional support. We have nurse practitioners that screen people preoperatively, and so there's a whole lot of people that are sort of on the team of organizing this care, and we have to be able to work together, through this whole process. And so this is like one of the things that's happening now is people are coming up with these sort of care delivery value chains of trying to figure out how can we maximize the value to the patient, because that's where the value is delivered. It's at the level of patient care. You want, value is basically bang for the buck, right? It's basically the quality of the outcome divided by the cost of achieving that outcome. So this is really the buzzword in all of medical treatment, but certainly joint replacement, is we want to give people the best outcome we can give them, and we want to make it cost effective for the system, for the patient, but also for the whole system. Rapid recovery. This is a kind of a big paradigm shift now where we're getting people up and mobilizing them earlier. Part of that's good pain management, early rehabilitation, and tissue-sparing surgery. Who's a candidate? This is elective surgery. This is not life-saving surgery. This is not coronary bypass surgery. This is totally elective surgery, which means it's totally up to the patient to do this. It's up to the doctor to say, I've run out of options for you, you're a candidate for it. But doctors don't really tell patients, you gotta get this done. Like you have to have a knee replacement or else, because it's not life-threatening. So to that extent, patients are the ones that decide when they want to get this done because they've exhausted all their other options and their quality of life has been severely affected and they're in pain. So pain is the number one motivator to get this done. People living in pain, eventually, it wears on you. And sooner or later, if you have enough pain, you'll say, I'll do anything. When I had it in February, that's when I said, stick me with a needle, I'll take anything to get rid of this pain. I'm done, and so people reach a tolerance point. Loss of function, can't do what I want to do, my quality of life is like in the gutter because of all these other things here. I can't sleep at night, I've tried everything else and nothing's worked. So that's kind of when you get to this. For the knee, there's various different options. Unicompartmental knee, so about 30% of patients only have arthritis on one side of the knee. The other side of the knee is normal. This is bone on bone. There's good cartilage over there. And a certain subset of patients, if they don't have too much deformity, if their anterior cruciate ligament is intact, if it's isolated and all their symptoms, and they come into the office and they say, it hurts right there, and they don't go, it hurts right here, they can put a finger on right where it hurts. Just replacing a single compartment of the joint is an option. This is what it looks like here. So this is the component here. This is a little plastic spacer, and there's a little cement that's fixing this to the bone, and you can see the joint space over there looks normal. It's good because it resolves arthritic pain. You maintain all the ligaments, and 2/3 of the knee is still yours, so it kind of feels more like a normal knee. It's done through a smaller incision, and it's a little bit easier for patients to get their range of motion back, so the recovery is a little bit faster. Total knee replacement, this is more reserved for when the whole thing is worn out or if patients have significant deformity There's a lot of different prostheses on the market. Everyone purports to be better than the other one. They're kind of like cars, you know, they all go from point A to point B, but Ford thinks it's better than Chevy. And so this has been around for 30 plus years now. It's pretty well established what the indications and the techniques and the principles are. And the results are compellingly good. At 15 years, 90+% of these things are still in. We're seeing patients now that we're sort of in our third generation of perfecting prosthesis design. We have patients that are out beyond 25 years. And so I think what we'll see in the future is as the materials get better, as we get better at putting them in, we'll get patients 30 years out of these things, I think. How's it done? You know, here's your worn out joint here. And so some people think like, are you literally gonna just like replace the knee? And it's not really that. We try to save as much as we can. So we're really just making these kind of measured cuts, resecting off the worn joint surface here. We're not like transecting the femur bone there. You know, there's a metallic component that kind of fits. These come in about 8 or 10 different sizes depending on the system you use, so you can measure it to the patient's size and anatomy to get the one that fits best. Similarly, you resect off the surface of the tibia bone here, which is the shin bone. You create sort of a flat surface there. There's a base plate. It's got a little stem that gets cemented down, and there's a plastic liner that goes in between them. So this is the new joint surface here, and because there's no bone on bone, it's metal on plastic, there's no nerve endings in it, and it doesn't hurt once it all heals up. Minimally invasive, this was a big thing about 7 or 8 years ago, the minimally invasive total knee replacement. And the long and short of it is people were trying to reduce the incision length from sort of a conventional 6 to 7 inch incision to a 4-inch incision. The cutting blocks that we used to make these measured cuts on the bone got kind of downsized so you could get them in through smaller incisions. And the concept was sort of reduced tissue trauma. As time has gone by, what we saw is if you tried to make too small of a hole, you couldn't see what you were doing. You know, and so what's interesting is this was a huge buzzword and everybody was like, I do it too, you know, minimally invasive knee. And then, you know, as a group of orthopedic surgeons doing 800,000 of these things a year, what people began to see is these things were being put in the wrong alignment because you couldn't see. And so this whole concept of like making tiny little incisions to make people happy about how cosmetic it was has kind of gone by the wayside because people now say, look, it's got to be put in right. If you want this thing to function and last 30 years, who cares if the incision is 4 inches or 6 inches? Because if it's 4 inches and it fails in 2 years and you got to come back and have it done again, you're going to have a 10-inch incision, you're going to be mad. So, you know, so I think the concept is we do want to try to reduce tissue trauma, but there's a limit. You got to get this thing in. It can't be put in through a hole that big. You know, so you got to be sort of realistic about maintaining the principles of how to do it right.
You can't have an incision with tattoo.
Yeah.
I've seen what happens.
Yeah. By the same token, we have patients with tattoos that come in and say, can you not go through my tattoo? Is there any way you can go around it? So, you know, this whole concept of smaller is better is a little bit gone by the wayside. You know, I think minimally invasive has now sort of changed to reduced tissue trauma. Not like, can you make me a small incision? It's can you do this without violating so much that you can get a rapid recovery. And the bottom line is that there was when people started doing this minimally invasive stuff, there was never any evidence that people did any better. You know, it really wasn't. So then people came out and said, haha, MIS, this is what, you know, maybe it's safe, it's insane surgeons, it's a scam, it's, you know. So we've gotten away from that a little bit. Computer navigation, this is something that's been around for a while, you know, using computers to help position these prostheses. You can put these are little infrared markers that are drilled into the bone, and they can tell the surgeon on a computer screen where the cuts are, where the implant positions are. These things are used by some centers. If you look at the scientific data, there's no evidence that people do better if their knee was put in with computer navigation. The human eye is very accurate. You know, if you're sort of making a measured cut of something, the human eye is very discerning about knowing when something looks right and is right or was, you know. And so, you know, plus the data that's captured by these things has a measurement of error that's a couple of degrees. So the bottom line is like, these are out there. Do they really make a difference? They really don't. They take more time to do the surgery. They add to the cost of the surgery. There's complications with their use, like people get pin site infections from where you drill the things in, and there's no real evidence that they're any better. Then there was this whole thing about customized implants. We can like create custom cutting blocks for you. You'll get an MRI beforehand. The computer will analyze the MRI and make these custom jigs that we'll put on your knee, and it'll tell the surgeon exactly how the thing should be put in. And the bottom line is these things have never caught hold. They cost $5,000, so just when we're sort of trying to curtail healthcare costs, now you're throwing an extra $5,000. And when people have looked at the results of these, the principles are you want these things well aligned, but what they were finding was these things were often malaligned. This thing should be straight down the pike. You can see it's angled a little bit over there. The angle of this prosthesis is slightly wrong. And so these things were just not as accurate as they were said to be. And so again, it was this concept that came out. It was a big marketing buzz. Everybody wanted to do it, but the results really are not. What matters is what do the scientific results tell us? Is it better? Direct anterior hip approach. This is a new thing. It's actually an old thing that's been kind of brought back. This is one of the original exposures for the hip joint that was done, 40 years ago. And then people got away from it because they thought it was harder to do it this way and started putting them in through the posterior approach, which remains the most popular approach. The posterior approach is very easy to do. It's very quick, but you do have to detach some muscles to get into the joint. So in this whole era of tissue sparing, people started to revisit this anterior approach to say, if you go in through the front, you actually can open up this interval between these two muscles right here. So this is the sartorius muscle here. This is the tensor fasciae lata. And you can go right through that interval there, and without taking anything off, you're right down on the hip joint. And so people developed sort of new retractors, new ways to expose this, new implants, and new insertion devices to be able to do this operation safely and relatively quickly, and basically just working through natural intervals in the muscle here. And one of the things that you can see, the hip joint here is actually closer to the front than to the back. So if you go in through the back, you got to split through the gluteus maximus muscle, and then you've got these little muscles on the back side of the joint there, and you got to take those things off to get in there. Whereas here, you can just basically go zip right through there and get in there. There's also a big yellow thing right there, sciatic nerve. So here, you've got the femoral nerve, but you're really on the other side of the muscles there. Whereas here, you're coming through, sciatic nerve is right there. So you need a special table to do this. You don't really need it, but it helps. And this table, basically, to get access to the canal of the femur bone, you've got to be able to drop the leg down into extension. One of the benefits of this approach is the patients are supine, so you're sort of lying there in a natural position. The posterior approach, you're on your side. And this table basically facilitates positioning the legs so that you can get the individual components in. It looks very complicated. It's actually easy to use. One of the other benefits of the direct anterior approach is that you can use x-ray. If you have a patient lying on their side, it's kind of hard to get x-ray in there and you can't really tell where the pelvis is. But if you have somebody lying flat on their back, you can bring the x-ray in, you can align the x-ray beam so it gives you a perfect view of the pelvis, and then you can use that to guide the positioning of the implant. So when we put these implants in, through a posterior approach, if you're looking straight into the wound, you're looking at it, there's the socket, here's the handle, tap, 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 that looks about right. Here, we're not even looking in the wound. We're looking on the screen. We can basically say, take a picture there, take a picture there, take a picture there. Okay, that looks good. Bang, bang, bang. Take a picture. And so it's, you're basically using image guidance in the operating room to make sure that the position of your components is nice. So one of the nice things is when you leave the operating room, you can say, it's good. Size, position, everything looks good. And that's kind of a nice feeling because with some of the other approaches, if you get your x-ray in recovery room and you don't like something, patient's already off the table, awake and in recovery.
How long does it take to be in the hospital when you get that? Talk about the direct anterior hip replacement.
Yeah, so one of the benefits is that it seems to be a little bit of a faster recovery because you're not violating the muscles. And so, you know, the duration of the hospital stay, there's a lot of things that go into it, including the overall health of the patient and whether they're going to go to rehab or go home, depending on what their home situation is. And so, you know, I think the way you got to look at these approaches is if you have an unmotivated patient, they're going to be unmotivated no matter how you put this in, and the approach isn't going to motivate them. And so, you know, but if you have somebody who's healthy and motivated and they want to get up and get going quickly, they can get up and going a little bit quicker. The discharge criteria after joint replacement are, you got to have 24 hours of IV antibiotics, you have to be comfortable on oral pain medications, therapy has to have cleared you, you know, to be getting around with crutches or a walker before you go home. You have to be safe, you have to be eating, and basically bowel and bladder function have to be working. That's kind of, and if you can do that in one day, you can leave the day after surgery. But in most people, it takes 2 to 3 days. You know, and so you might have more people with an anterior approach that get out on day 2. You might have the occasional superstar that gets out on day 1, and you're still going to have people that get out on day 3, just like a conventional posterior approach. But usually what we see is that the amount of time that you have to be on crutches or a cane is a little bit shorter because you're not violating these muscles. And so people tend to walk into your office at 2 weeks and they're not on a walker like they used to be. They're walking in on a cane or nothing with a direct anterior approach.
Are you using these tables locally now?
Mm-hmm. Yeah. And also, you don't have to have hip precautions. So in a total hip replacement, you know, the traditional approach is you'd have to put a pillow between the legs, and for a long period of time, you couldn't bend past 90 degrees. And so with the anterior approach, because you don't have to wait for the muscles to restabilize the joint, we don't really force these hip precautions on people. You kind of just, you educate people on, you know, certain positions that you want to avoid, but you kind of let people go and you don't tie them down with precautions. Hip resurfacing, this is kind of a development that's been around for about 10 years. The concept is you don't cut the neck off and put the stem all the way down like a standard hip replacement. These things have been a little bit controversial because it's a metal-on-metal articulation. There's been some, you've probably heard press reports about, you know, bad things happening with metal-on-metal, with tissue toxicity and rejection and ion levels in the blood. And so some people have gotten away from these. There's also been some problems of the neck of the femur fracturing around these pegs, and so the complication rate was a little bit higher when we first started to use these. The other thing is because you don't cut the ball of the femur off, you just kind of cap it with this thumbtack. All this bone is still up under there. It's very hard to do a tissue-sparing approach when you got all that stuff in your way. You end up having to actually do more tissue damage to shove that out of your way so that you can get to the socket. So to some degree, it's almost, even though you can say, well, it's bone preserving, but it's also more tissue invasive to get the thing in. So I don't do these. You know, there's people around that do a lot of them. I just don't really see what the benefit is. To me, when I look at this, I ask, who needs that wouldn't do just as well with a standard hip replacement? I don't really know. Surgical approaches conclusion. Literature is available to support the use of most surgical approaches. The bottom line is and people have compared, is the anterior approach really better? Or is it just a marketing tool, you know? Or are we just saying that we do it, you know, because patients want it? The bottom line is at 6 weeks, everybody looks the same. No matter how you put these things in, at 6 weeks, everybody does great because it's a great operation and people have pain relief and they're getting around. Most people are off the cane and the walker. Most people are doing very well by 6 weeks. The main benefit is in the first probably, you know, 3 weeks. People are getting going a little faster. If younger people need to get back to work and they can't take 6 weeks off, the anterior approach may get you there a little bit faster, you know, get you off the cane a little bit faster. And so, but by 6 weeks, everybody's doing great. So, you know, I have patients that come into my office because they know I do this now, and they say, like, it's negligence to do this any other way. What I've heard people say is that it should never be done any other way. And that's simply not true. I think the whole thing has gotten blown a little bit out of proportion because the bottom line is you can still do a great operation through a posterior approach. There's some people who are not candidates for the anterior approach if they have major deformity, if they have developmental dysplasia of the hip, if they have hardware from an old hip fracture in there, if it's a revision case. You know, cases like that, you just can't get enough exposure anteriorly to do a good job. So we still do posterior approaches in select cases. So it's a little bit of, you know, you got to pick the right problem, the right patient, the right approach. So it may not be for everybody. And the bottom line is can't forget the principles. You know, a lot of the success of these operations is based on sticking with the principles of how they work and what works. And you can't abandon principles just for the sake of a cute little incision and an anterior approach if it's not the right thing to do. So,
My urologist had his hip replacement done, and in 2 weeks he was back in the office. He was assisting, watching, supervising surgeries. But in 4 weeks he was doing surgery again. Unbelievable. I couldn't
yeah.
believe it.
I mean, if you, and people have studied this, so here's like another little fun fact for the evening. People, health economists, so there's people out there that are like economists that are focused on the economy of healthcare. And one of the things that they measure is if Medicare is going to pay money for you to get your joint replaced, you know, then Medicare wants to know that it's worth the money, right? That you're going to get better, you're going to get back to work, you're going to be a gainful person to society, you're going to be a contributing member. That's what they want, you know?
We're sending him Parsons, he's
Yeah.
already back to work.
So there's this measure called health-related quality of life improvement. It's some measure that healthcare economists came up with to measure the comparative benefit of various different things. In other words, what's the benefit of a coronary artery bypass graft versus a kidney stent versus a hip replacement versus a whatever, you know? How do these things stack up against each other? And you know what the number one operation in medicine is? It's a hip replacement, because people do so great. They get back to doing what they want to do so quickly. And you know, after a hip replacement, once the thing's all healed up, literally nowadays, because the bearing materials are so durable, you can tell people, you do whatever you want. Go skiing, jump out of a plane, I don't care, you know? So you know, when you compare it to other procedures in orthopedics, but also in medicine at large, it is probably the best operation in medicine, because the complication rate is low. You can take people that are severely disabled by pain, and when a well-done hip replacement is fully healed up, if somebody's like 2 years out from surgery, you know, if you ask a lot of these people, can you even tell that it's in there? Do you even know that you have an artificial hip? A lot of people will go, I don't even think about it. I don't even know it's there. You know, it feels like a normal hip to me. Knee replacements, most people will tell you, like, yeah, I can tell it's not my normal knee. It clicks, you know, it makes some noise, it gets a little stiff still. But a hip replacement, people don't even know it's in there. It's amazing.
Did you say 2 years it takes to get over that?
I think most operations in orthopedics, we tell people it takes a year to be as good as you're going to get. That's true of a lot of things, rotator cuff repair, knee replacement, you know, and everything in life is a bell curve, which means, you know, the 50th percentile, that's the top of the bell. That's where most people are, and we tell people it's going to take, you know, 9 to 12 months before you're not thinking about it that much, where you take 10 steps and go, yeah, it's a little bit sore, where it's like not, you know. And then there's people where it takes 3 years, you know, there's some people that never get fully better. And then there's people that by like 4 weeks, they're like, I'm good. So, you know, it's a spectrum for people. I put this slide in as just to sort of beware. You know, there's a lot of contentions out there. Stuff like, if you had your hip replacement any other way, it's like malpractice nowadays if it wasn't put in through the front. That's just not true, you know. And so sometimes the Wall Street Journal and the New York Times, they get a hold of some of this stuff, and the media, you know, kind of inflates some stuff. And the companies that make these prostheses are marketing directly to you on TV now, you know. You gotta have the get around knee or the blah, 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 you know. And so You know, the bottom line is that there's just a lot of snake oil out there, you know, stuff that purports to do what it doesn't really do. A lot of these assertions are really not backed by scientific evidence. And so again, like my pitch to people is like, you know, when you're going to get something done, having an operation is like buying a flat screen TV, you know. You got to do some research on it. Like if you're going to have a joint replaced, learn about your surgeon. You know, learn about the hospital. What's the hospital complication rate? What's their infection rate? What kind of prosthesis are you going to use in me? What are you putting in me? It's amazing how few people ask me, what are you putting in me? When there's 15 to 20 different prostheses on the market, people don't ask. You know, how many of these have you done? What's your complication rate? How many of your patients have gotten an infection? How many have been dislocated? Maybe people don't feel comfortable asking those questions, but the bottom line is if you're going to buy a new car, you want to make sure that the thing's going to last for a long time, it gets good gas mileage, it's reliable, and it's not going to be in the shop all the time. You know, and to some degree, you know, having a surgery or just getting treated for a condition, you know, healthcare is a consumer business. You're paying money to get treated, you know, so you should be an educated, savvy consumer. If you're paying money and it's taking time out of your life and you got to make an investment in time and money, you know, and the emotional turmoil and the effect on your family of being sick or whatever, you know, educate yourself. Make sure you're making the right decision. So, Obamacare? I don't know what's going to happen. You know, so a lot of people say, I mean, I literally am having patients come to the office now saying, like, I need to get I didn't want to do it, but I'm worried that come January, I'm not going to be eligible, and so fix me now. Because I knew I was going to do it eventually, you know, I was hoping it was going to be in 2 years, you know, but it's, you know, some people say Obamacare, you know, maybe some people are not going to be eligible for this now because of limitations of Obamacare. It's going to be rationed, there's going to be strict criteria, and the government's going to put handcuffs on me and say you can only do joint replacements on people, you know, if they meet certain criteria. And I'll be telling, don't look at me, you know, like, you know, and this is true. There's going to be a surcharge on medical devices, which means the government is going to tax the implant companies, kind of like they tax like cigarette makers, you know. There's going to be a surcharge on medical device companies where the companies are going to get taxed. And so the result of that is that on one hand, you're taxing the device companies, right? They're trying to make money because they're publicly traded companies. That's what they do. They make money selling implants. Then you've got downward pressure on reimbursements on the hospital, you know, where in the future, what Medicare is going to say is they're going to say, you know, fee-for-service days where you just do an operation and then you charge us for the surgeon's fee, the anesthesia fee, the hospital stay, all the like bandages that you put on the medication, that's over. Here's what we're going to pay you for a hip replacement. We're going to pay you X amount of dollars, and if you can do it for less than that, you guys can keep the change and split it up however you want to split it. And if it costs more because the patient has a complication or their length of stay is longer or they need to go to a rehab facility for 3 weeks or they get an infection, it's on you. Sorry, because we're only paying you X. And if it costs more than that, you're assuming the risk and the financial difference. And that's where things are going. And then what'll happen is if you have a hospital and they're killing it, they're like coming in under the number, they're making a profit on every case, you know what Medicare is going to say? We're dropping the reimbursement rate because you're making too much money. And so there's going to be a continued downward pressure at the same, and so, you know, the hospitals are going to be going to the implant companies, you got to drop the price on these things. We can't pay $5,000 for the implant because, you know, we're like at this narrow margin right now. And the implant companies, yeah, but we're paying a 2.3 surcharge sales, you know, so nobody knows like where this is going to end up. Nobody knows. And so people come to me and they go, what's going to happen what's going to happen to you? And I'm going to show up on Monday, you know, hopefully somebody, you know, so it's, I don't know where it's going. The bottom line is you know, the goal of treating arthritis, the goal of joint replacement, the goal of patient care, you know, patient satisfaction. This is about you guys and patients with problems. We want patients to be satisfied with their care and their outcome and their experience. It's got to be safe, you know. We want to do things that work. So we want treatments that work for people, not snake oil. We want long-term outcomes, which means we don't care what it feels like in 6 weeks if it's a 30-year operation. You know, that's why this whole thing of like, gotta be the anterior approach. You know, early recovery is important for people. If they got to get back to work, it's important to get better quickly. But the bottom line is, it's still got to be done right. You know, this is a 30-year solution. This is a long-term horizon. This isn't, where do you know, my friend was off the cane in 10 days and it took me 17. Who cares? Because in 6 weeks, you're going to look the same, you know. So patients get caught up in these things. What really matters is the long-term outcome. The short-term outcome is important too, but the long-term outcome is more important. And cost effectiveness, you know, we want to be able to do these things and not bankrupt Medicare, not bankrupt the government, not put in unnecessarily expensive things, you know. You got to match the implants. You know, if you have somebody who's 87 who just like, you know, buys groceries and goes to church, they don't need a high performance, high functioning ceramic NASA designed implant. They just don't need it because they only need to get 10 years out of it probably and they're low demand. And by the same token, if you put that implant in somebody who's 45 who wants to ski, it's going to wear out in 10 years, you know. So you got to sort of be cost conscious. So that's all I got. I'm happy to answer any questions, or if people want to storm the podium and just get me privately, I'm happy to do that too.
What do you call the other surgery? Not the direct anterior, but the one that, if you didn't have that, what's the other one called for hip?
Posterior approach. There's 4 approaches really. There's the posterior, there's the lateral, the anterolateral, and the direct anterior. And all of them work. They all work and they all have their own little set of pluses and minuses, but they all work. The posterior approach is far and away the one that has been most commonly done.
Posterior?
Yeah. Posterior is just like Latin for the back.
Oh.
Anterior means front, posterior means back. So anterior approach, the incision, if you feel this kind of bumpy bone on the front of your pelvis and you go about like 2 finger breadths down, and that's where the anterior approach is right there. The posterior approach is sort of, if you feel this prominent bone here, the posterior approach is sort of back there. And so you got to split through that gluteus muscle to get in there to do it.
Would arthritis in your spine be considered osteoarthritis?
Yeah.
What's rheumatoid arthritis?
Rheumatoid arthritis it accounts for probably maybe 10 to 15% of cases. It used to account for 40%, and it's gotten less common. Rheumatoid arthritis is a condition where your body's immune system thinks that your joint is like a virus. And so what it does is it starts building antibodies against you. And it starts degrading cartilage in the joint. So essentially it's like your immune system is attacking you. It's an autoimmune disease like lupus or like some of these other immune diseases.
Another question. Is it usual when you have arthritis in your spine to have nerve involvement where you'll have tingling and numbness in parts of your body?
Yeah. So,
Is that called radiculopathy or is that something else? Have you ever heard of radiculopathy?
yeah, so radiculopathy is like pinched nerve. Radiculopathy is classically associated with a herniated disc, which is a little bit different than osteoarthritis. So you can have a perfectly normal spine with no arthritis, and the disc, which is like the little jelly donut in between the vertebrae, gets a hole in it, and the jelly squirts out, and it compresses the nerve, and you get a searing nerve pain, and your x-rays look perfect. That's classic radiculopathy. Radiculopathy meaning the nerve pain, and it usually goes down the leg. And people, does your back hurt? No, my back doesn't hurt. My leg's killing me. That's radiculopathy. So, but you can get osteoarthritis, which usually happens in combination with degenerative disc disease. So what happens is the discs, which are like these little fluffy jelly donuts, soft and compressible, over time they dehydrate and they compress down. They bulge out, and then as the bones begin to approach each other, they start getting bone spurs. And the little joints in the back that shingle the vertebrae together start getting bone spurs, and then they start to impinge on the nerves. And so it's not like a one-shot single, like, on a single nerve root. It's a general, it's like spinal stenosis or narrowing of the whole area because of encroachment of bone spurs. And the classic symptoms of that is not so much one nerve root, one searing pain in that nerve root. It's more generalized buttock pain, leg crampiness. You see people in the grocery store pushing the carts like this because it feels better to lean forward. And so it's a little bit different than radiculopathy.
Could bone spurs from arthritis cause that as just on its
Yeah.
own, or would it have to be in conjunction with the?
No, bone spurs can cause it alone. So, and that's really common, And the spine is one of the big areas where people get arthritis, and it's because other than giraffes, like we're the only vertical species. Every other quadrupedal species, is horizontal. Their spines are horizontal. So, there's like a funny saying in medicine, gravity always wins, right? Like plastic surgeons like to say this because like people start to droop with time because of the effect of gravity on tissues. And, the spine is like no exception to that. The effect of gravity on being vertical over time, these things just...
Are you with two hospitals, Frisbie and Wentworth, that's both?
Yep.
Yeah.
Yeah.
If you have osteoarthritis of the spine, can you have cortisone shots?
Yeah, so you can get epidural steroid injections into the lower back, which is fairly safe because there's a lot of room back there. And the spinal cord actually ends right about here. And below that, it's all just nerve roots that come off. And so down kind of below the junction between the thoracic spine, which is here, and the lumbar spine, which is there, there's a fair amount of space back there that you can safely, just like you would do a spinal anesthetic, for like a C-section or something, you can safely put cortisone back there. And some people can get dramatic relief from that, and other people don't really get much relief depending on the situation. If you go above where the spinal cord ends, into the thoracic or the cervical spine, cortisone shots are dangerous because there's almost no extra room there. And so you're sticking a needle in there, and if you stick a needle into the spinal cord, you can paralyze somebody. So I personally don't think that cortisone shots are safe above the lumbar spine, but they are safe in the lumbar spine for certain.
What can you do with fingers and toes?
I don't know. Yeah, I mean, fingers are tough. They actually do make little silicone implants for finger joints. Literally, like little tiny joint replacements that you can put in finger joints.
So it'll straighten the finger out?
Yeah, I mean, theoretically you could do it. I don't actually do hand surgery, so I don't have a good idea of do they work, do they last, are they any good, or should you just like live with it and try not to use I mean, the problem is like you got to use your hands, right? And but I can tell you that they do make these little silicone implants that you can put in there. Classically, if people had severe arthritis, the surgery was kind of clip the bone spurs, sort of try to just take the bone spurs off, and sometimes even fuse a joint. So a fusion is like a historical treatment for arthritis. If a joint's worn out, fuse it together, right? Because if it can't move, it can't hurt. I mean, motion is what causes the pain. So, fusion surgery, we've gotten away from it because it's limiting. If you fuse somebody's knee, it's stuck in extension. They sit down in a chair and their legs out like this. And, and there's people out there with fused knees who had, war wounds and things like that. And you can fuse fingers, but then you can't bend them, so then you lose range of motion and it's not very functional. So if the pain is bad enough, like you could fuse it, or you could do sort of like a remove the bone spur operation, or you could consider like a silicone joint implant. And the person to talk to would be to see a hand specialist. Now toes are a little bit different because toes, you don't manipulate them for sort of fine dexterity. So if toes get arthritic, you can do what's called a resection arthroplasty, which means you just cut the joint surface out. And it becomes like a floppy toe where there's no joint, surface. But you can live with floppy toes, believe it or not, because your heels and the balls of your foot, work pretty well. And so you can kind of create floppy toes in people, and they seem to do fine.
You can't have cortisone in the finger.
The finger joints are so small, they're very difficult to get cortisone into because it's just such a tiny little space. You know, so it's like you'd be probing around with the needle going, hit the bone, and because they're so sensitive, right? Like you can put a shot in the butt, people don't feel it. You know, but the fingers are so sensitive that if you were probing around and, you know. So the one that you can do, the base of the thumb, this is a common joint where people get arthritis in the base of the thumb, and that one's big enough you can get cortisone, but the little finger joints, I think they're just too small and too sensitive to get cortisone in them. You could try, but I think patients would hate you, you know. You'd be miserable. You'd never want to do it again. You'd do it once and be like, never doing that again.
Having trouble, 2 fingers,
Yeah, well, you might, I mean, do you have a trigger finger? Because that's different. Some people get a trigger finger.
This one is, but this one is, it's arthritis, I have pain in it. And
Yeah, because a trigger finger, you get a little nodule on the tendon, and you can inject that with cortisone, and the trigger goes away, and then people can move it again.
this is the important one, and you said can't do anything.
Yeah, well, you can always get a second opinion. You can always get a second opinion, you know. Seriously, I mean, you know, every doctor sort of has their own way of looking at things, and you know, there's science. You know, I mean, people call medicine an art because there is not science to back up everything we do, right? We do have some scientific data, and not all scientific data is good, right? There's a lot of bad scientific data out there. If you've read, you know, if you listen to the news, you'll hear reports on the news of like fraud detected in like this study or that study, and it's because this multi-billion-dollar industry is trying to inflate their data to make their product look good so people buy it and prescribe it, you know? So there's a lot, that stuff goes on in the scientific world, so not all data is good data, and we don't have data for everything that we do. We have experience, you know? And experience is, you know what experience is based on? Your best and your worst outcome. Experience should really be based on the top of the bell curve, right? Because that's really where you want people. You want people right at the, I mean, you want people 2 standard deviations above the mean. That's like everybody's a superstar. But really what you want is you don't want people on this side of the bell curve where they're doing poorly. So if you shoot for the 50th percentile, everybody's doing good, right? Everybody's happy, everybody's doing good. And so, you know, the problem is as in medicine, a lot of times what happens is we remember the superstar because they made such an impression on us. We did this and it worked so great. You see how great that person did? And we remember the disaster, the total disaster, because we had to take that patient back to the operating room 4 times, you know, and it was awful, right? Those are the things that we remember. So we remember the like, that worked, that didn't work, right? But we don't really think about everybody here because, you know, they're happy, we're happy, you know, whatever. But that's really what's important is the middle. And so, you know, one of the problems with medicine is that if we don't have a lot of data and we're relying on experience, sometimes experience is clouded by the disasters and the superstars and not necessarily everybody in the middle. And that's where data collection is really important. You know, the more data that we can collect on people and analyze the data, the better. But in the course of a busy practice, collecting data on people and then taking time to sit down and analyze it is very difficult to do. So, you know, and there's no really great solution for it. You know, so the bottom line is that every surgeon has a bit of a different perspective on their own experience of what worked and what didn't work. You know, so you might see, it's like me with glucosamine, right? At first, don't take that stuff, it's a waste of money, you know? And now look at me, I'm like, yeah, this stuff's great, man, it works great for me. So people's experience changes, and so you might see one person and they'll tell you like, nah, don't waste your time with that silicone implant. It's a disaster. I did one and it fell apart and I'll never do another one again because the patient had a terrible outcome. And you might go to somebody who does 100 a year and they go, yeah, they do great. I do tons of these things and patients do great.
2 years ago, I got a shot of cortisone on my shoulder from you, and it's been fine.
The miracle drug.
It was terrible. I was in horrible pain, just like you.
Yeah, I mean, horrible pain will compel you to get needles stuck in you, right?
Next time you have a pain, call it.
It does. When I got mine, I had done 2 hip replacements. It was a Wednesday morning, and I had a day where I had 2 surgeries in the morning, and I was coming back to see patients in the office in the afternoon, and it had been kind of escalating. And hip replacement, there's some carpentry work involved, so, joint replacement as a surgery, it's not like hand surgery where it's like really delicate, It's basically like you can see, we make cuts and we put stuff on and we tap it on, and there's some manipulation because legs are bigger. You've got to position people's legs, and so after these 2 operations, it was killing me. I mean, I was just like, and it was like this constant, just like I can't even find a position to like get this thing to settle down. And so I was driving back to the office, and it was lunchtime, and I was like, I cannot wait to get to the office because I'm going to get this thing injected. And cortisone injections, they kind of hurt, particularly when you put them in the joint. So I go find my partner, Dr. Toot, and he's going up to lunch. I say, you got to come with me for a second. I need a cortisone injection. And you can either put them in the joint or put them in the bursa. And the bursa ones are pretty easy. The joint ones are kind of hard to get them in there. So I go, I need you to put it in the joint because that's where the problem is. He goes, I don't know if I can do that. He said, I usually send those to Fred, and Fred does them under ultrasound guidance. I don't know if I can get it in the joint, And I'm like, I don't care. Honestly, just put it there. If you have to probe around and hit bone, I don't care. Just get it in. And he got it in. But literally, like, pain will drive you to that. Like, where at one point, I don't want to get this thing in. I don't want somebody sticking a needle in me. I mean, I don't like needles. I don't even like getting a flu shot, right? Every time I got, I get a flu shot. But I was like, take the biggest needle and just, that's what pain will do to you when it gets bad enough. So.
The hip joint, actually, the outside is the bursa, is that what you call it?
Yeah, the bursa of the hip joint is kind of out here on the side.
That bone is, that round bone?
Yeah, so sometimes people come in and they say like, yeah, my hip hurts, And you go, oh yeah, where does it hurt? Hip arthritis classically hurts here, groin pain. Yeah. So patients get referred to us commonly for hip pain, and we go, where does it hurt? And they go, oh, yeah, it hurts right here, And that's usually lower back. If it's over here, it's usually hip bursa. If it's here, it's usually hip joint. Yeah, arthritis is most commonly here. So, does anybody live more than 20 minutes away? Because if you do, you better get on the road if you want to make first pitch. No, I'm just kidding.
More than 20 minutes away?
Do I? I can't. Patients today in the office, I was in the office, said, you going to watch the game tonight? And I said, I don't think I can. Like, it's too stressful. It's like they could win it all tonight. This is like, And I'm like, I don't think I can listen to it. It's way too stressful.
Because when you live more than 20 minutes away, will you make it to the game?
Oh, it's 8:05. What do we got? 22 minutes?
Make it.
Yeah. Yeah, I'll make it. I'm not a big baseball fan. I'll wake up tomorrow morning, check CNN in the morning, check the headlines.
Doctor, you said that arthritic hip pain would be in the groin?
Most classically, it's in the groin, but in some patients, it radiates all the way through. So some patients will have pain in the back. So, but bursa pain is almost always like right there on the side. So if patients come in, you got to sort of feel around and say, where does it hurt? Because sometimes people say it hurts right here, and you go, well, does it hurt right? I like to do what's called the one finger test. Patients will come in the office, and you go, where does it hurt? And they go, well, it hurts right here, And they kind of put 2 hands on there and 10 fingers, and you're like, well, that's like, And then I say, 1 finger, 1 spot, and they go, oh, geez, I don't really know. And you go, no. 1 finger, 1 spot. And they go, well, And you basically, if you make people do that, they'll find 1 spot, and then they'll basically say, like if they say it's right there, then it's bursa. And if they say, well, it's really right back there, then it could be sciatica, it could be referred pain from the back, or it could be an arthritic hip that sort of people are feeling it more in the back because the joint kind of goes all the way through there.
If you have a bursa problem and you got it straight, does the bursa problem eventually go into your hip?
Go into the joint?
I mean, would it affect your joint?
No. Totally exterior, not related. Separate deal.
What about a numbness that happens from the hip to the knee after you've been walking or standing for about 10 minutes, and then you sit down and it's fine, and then again, 10 minutes sciatic, they don't know what it is.
IT band, is that?
No, that wouldn't do that. I mean, classically, numbness, you think nerve, right? And so if it's nerve, then it's either central or peripheral, right? If it's central, it means you got a pinched nerve in your back, and it might not be sciatica because the sciatic nerve doesn't go to the front. The sciatic nerve goes down the back. So if it's in the front or the side, then it's not the sciatic nerve. But by the same token, you can have a herniated disc or arthritis pushing on any nerve root anywhere. And so if it's high enough up, like at the third or the second lumbar level, you can get pain in the front of the leg. And it's like sciatica, but because it's not the sciatic nerve, it's a similar process, but a different nerve. But the other thing that people can get is something called neuralgia paresthetica, which is the sensory nerve to the thigh. It comes out of the pelvis and it goes right over the brim of the pelvis, right here, and it travels down the leg. And neuralgia paresthetica is a condition where that nerve can get compressed and give people numbness and burning that happens right down there. And sometimes it can have people like truck drivers get it because they're sitting, and if their belt buckle's too tight, it pinches on the nerve. And so, you know, it's usually either neuralgia paresthetica or it's a referred pain coming from a pinched nerve higher up in your back.
And rheumatoid arthritis, why is the cartilage breaking? It's not a wear and tear if the synovium is being inflamed, right?
Yeah, the synovium is the lining of the joint, and it's what makes joint fluid. Yeah, and you get severe synovitis or inflammation, and the synovium starts making enzymes. Enzymes are proteins that break stuff down. So like when we eat food, our food gets broken down by enzymes, and the synovium produces enzymes that break down the cartilage as part of the inflammatory process. And some people, if it's severe, they can go on to just horrible joint destruction. You know, if you see the really bad rheumatoid patients, we don't see them very much anymore because the medicines have gotten so good, people are in much better control. But in the past, when the rheumatoid medications weren't nearly as good, the sort of immune modifying medications, I mean, you'd see people with just like, you know, floppy elbows and what we call the windswept fingers, where the fingers were just like wind chimes, you know, the joints were just completely destroyed. And I mean, it can be horribly destructive for people, you know, and some people just get it, they get it everywhere, they can be riddled with it.
As an option to surgery, if a person is really afraid of having surgery because they're older, say, long-term NSAIDs and cortisone injections, would that be an option?
Yeah, I mean, long-term NSAIDs is a good point. So, you know, NSAIDs meaning Motrin, Aleve, ibuprofen, things like that.
Or Celebrex?
Celebrex, yeah. I mean, typically, the thing that we counsel patients on is these things are metabolized by your liver and your kidneys. So if you're on them for long periods of time, you should periodically, and the party line is usually once every 3 months, have your liver and kidney function checked and make sure that it's normal.
With blood work?
Blood work, yeah. And if it's normal, it's okay. And if you start seeing like a little renal kidney insufficiency or something like that, you may have to give yourself a break from it for a period of time, you know, or switch to Tylenol or something. So, but the bottom line is if you're checking it periodically, it's safe if your numbers look safe.
This is kind of an open question. How do you unpinch a nerve? If a nerve is causing tingling or physical therapy?
Yeah, physical therapy can help. So if it's like a radiculopathy, let's say that you got a herniated disc and it's like sitting on a nerve root.
Yeah.
The good news is that in a lot of those cases, your body's immune system will sort of attack that disc and break it down with time, and it'll shrink down and remodel, and the symptoms will get better. So a majority of people with sciatica will get better just with time alone. So occasionally people don't. Physical therapy can help, and they can do these inflammation-reducing modalities, and sometimes traction if they do.
Chiropractic manipulation, or is that dangerous when you're working with nerves? I mean, it's one thing to adjust something, you know,
Yeah,
that's out of whack or whatever, but I'd be afraid, because people have said, I should see a chiropractor, and I'm kind of leery because I don't want it to get worse. If they manipulate me and the nerve gets pinched worse, then, you know.
Yeah, I mean, I think that there's a role for chiropractic, and I think, you know, people think that orthopedic surgeons don't believe in chiropractors, and that's not really true. I mean, I think there's a role for a lot of these things, and like you said, I think, like, number one, like everything else in life, there's like there's good orthopedic surgeons and bad orthopedic surgeons, right? There's good chiropractors and bad chiropractors. And so, there's chiropractors that tell you they can cure the common cold and cure asthma with chiropractic, and you go, really? I don't see how that works. But, but then there's chiropractors who really are good, and they understand, hey, this is a nerve problem, and we can't fix this, or we can make some small adjustments and it might help, but, we got to be careful. And so, I think in general, chiropractic is definitely good for people who may have some things like degenerative disc disease, where it's not like a radiculopathy, it's not an inflamed nerve root. You got some wear and tear, and the way that your back is setting off this muscle spasm, it's throwing off your hip joint because now you're walking around like this all day. Some of those things that can be sort of readjusted, I think chiropractic can make a huge benefit for people. And I think we're all for it. When patients come to see me, what do you think about fine. But I think in the lower back, maybe it's not as dangerous. If you have a pinched nerve in the neck, again, where there's not a whole lot of wiggle room up there, and people can get it. It's like radiculopathy, but it's arm pain instead of leg pain. Yeah, that I would not do. I would not have a chiropractor manipulating my neck. Yeah.
I still do get a little tingling in these three fingers from the arthritis in my neck. That's once in a while tingling, but nothing bad.
Yeah, and typically we tell people, it's not bad. If you can live with it, live with it. Yeah, and the last pitch I'll make to people. Yeah, shut up. Okay, you're done. I mean, the other thing I'll say is, we're all used to like living with a little bit of pain, right? Like once you get like 35 to 40 plus, something always hurts, right? You're never like 100% pain-free. I mean, probably very few of us are walking around saying, nothing hurts, nothing. Like my shoulder hurts and I got a sore back, But the reality is that most of us can live with that. Most of us are willing to tolerate a little bit of pain, and that's okay. Like what I try to tell some people is like, it's okay. And I tell this to my kids all the time because my middle daughter is like a total hypochondriac. She'll come in and she'll be like, it hurts like right there, and it doesn't hurt there. But if I push like right there, and then if I push there too, and I'm like, you're way too focused on it, If you're focusing that much on the pain, it's going to consume your whole life. You're going to be debilitated by it. Forget about it. It's nothing, I think to some, some patients they can get totally consumed by pain, and minor things like tennis elbow can become a cancer in their mind, And other people deal with it really, really well, and they manage it. And I think in general, the more that you can accept, we're all going to have a little bit of pain. It's okay to live in pain. You tolerate it, you manage it, the better. The more you fixate on it, and the more it becomes cancer, when it's just tennis elbow, the worse it's going to be.
But everyone tolerates pain differently.
Right.
I think sometimes the more pain you've had, you're able to tolerate a lot.
Right, and that's where I think self-management is key. Is that if you learn about it and you empower yourself and you take an active role and you exercise and you do all these things, you don't fixate it on it as much. You're fixating on other things, and then you're not thinking about it. So.